Hello, and welcome to the fourth Pharmacy 15. In general, exercise stress testing is preferred as a gauge of functional capacity, exercise tolerance, and symptom provocation. However, in patients unable to exercise, pharmacologic stress testing is an alternative. This week, we will cover part one of the cardiac medications, focusing on the interventional or pharmacologic stress medications. There are two types of interventional stress testing medications, vasodilators and catecholamines. The vasodilators include dipyridamole or prasantine, adenosine or adenocard, and regadenoson or Lexiscan. The one catecholamine is dobutamine or Dobutrix. The vasodilator medications do not really stress the heart, but simulate coronary steal phenomenon by temporarily increasing blood flow to normal or non-diseased coronary vasculature at the expense of diseased vessels, resulting in a difference between non-diseased and diseased arteries. Inotropic agents change the force of the heart's contraction. Chronotropic agents increase the heart rate. Dobutamine is a catecholamine that has both inotropic and chronotropic properties depending on the dose. We're going to start by discussing the vasodilator agents and specifically dipyridamole. Dipyridamole was the first pharmacologic stress agent we used back in the late 80s, and it was a nasty drug. It was in a pill form that we ground up into a horrible yellow paste that the patient swallowed. It took 45 minutes to an hour to work, and the patients invariably threw up every time. The only way we knew it was working was to note an eventual drop in their blood pressure. Thankfully, IV dipyridamole came out, but it still had a lot of problems. Its one benefit is that it's cheap. IV dipyridamole is an indirect coronary vasodilator. It increases the tissue levels of adenosine by preventing the intracellular reuptake and deamination of adenosine. We don't have time to discuss the mechanism of action on a cellular level, but you should be familiar with it for all of the pharmacologic stress agents. Dipyridamole causes a 3.8 to 7-fold increase in coronary blood flow velocity. Dipyridamole-induced hyperemia lasts more than 50 minutes. However, the peak vasodilation after administration occurs about 6.5 minutes after the start of the infusion. The half-life is approximately 30 to 45 minutes. Dipyridamole results in a modest increase in heart rate of about 20 beats per minute and a decrease in both systolic and diastolic blood pressure of about 14 millimeters of mercury. The patient should not eat or drink for at least 3 hours before administration and avoid any methylxanthines, including any caffeinated products and theophylline medications for 12 hours. 0.5 milligrams per kilogram of dipyridamole is diluted in 50 mLs of saline and infused IV using an infusion pump over 4 minutes. The maximum recommended dose is 65 milligrams total. The radiotracer is injected 3 to 5 minutes after the completion of the dipyridamole infusion. Indications for early termination of dipyridamole and reversal include severe hypotension, where the systolic blood pressure is less than 80 millimeters of mercury, development of symptomatic, persistent, second-degree, or complete heart block or other significant arrhythmias, wheezing, severe chest pain associated with ST depression of 2 millimeters or more, signs of poor perfusion such as pallor, cyanosis, and cold skin. Technical problems with the monitoring equipment or the patient's request to stop are also reasons to terminate the stress test. The reversal agent for dipyridamole is 125 to 250 milligrams of aminophylline given intravenously. Indications for dipyridamole are the same as other stress testing, but specifically for patients unable to exercise or who have EKG abnormalities such as left bundle branch block, Wolff-Parkinson-White syndrome, or permanent ventricular pacing. Contraindications to dipyridamole administration include bronchospastic lung disease with wheezing or significant restrictive airway disease, systolic blood pressure less than 90 millimeters of mercury, uncontrolled hypertension greater than 200 over 110 millimeters of mercury, ingestion of caffeine or methylxanthines, known hypersensitivity, unstable angina, and acute coronary incident within 2 to 4 days. Relative contraindications include heart rate less than 40 beats per minute, second or third degree atrioventricular block without a pacemaker, severe aortic stenosis, or seizure disorder. Side effects are common and occur in about 50% of the patients. Symptoms may last longer than other vasodilators, usually about 15 to 25 minutes, and may vary significantly among patients. And monofilin is often required to reverse the side effects. The side effects include chest pain, which occurs in about 20% of patients. However, chest pain is not specific and necessarily indicative of coronary artery disease. The other side effects occurring in 2 to 12% of patients include headache, nausea, dizziness, and flushing, ST segment and T wave changes, ventricular extrasystoles, hypotension, atrioventricular block, and drop in systolic blood pressure to less than 90 millimeters of mercury. Now let's talk about adenosine or adenocard. Adenosine was the second pharmacologic stress agent to come along, and we thought we'd died and gone to heaven. Adenosine is a direct coronary arteriolar vasodilator by activating adenosine receptors, including A2A receptors. Adenosine causes a 3 to 4-fold increase in myocardial blood flow. Myocardial regions supplied by stenotic coronary arteries have an attenuated hyperemic response. Depending on the severity of the coronary stenosis and coronary flow reserve limitation, a relative flow heterogeneity is induced. Myocardial tracer uptake is proportional to the regional myocardial blood flow, resulting in a heterogeneous distribution of the radiotracer in the myocardium. Peak vasodilation occurs 1 to 2 minutes after the start of the infusion, and the pharmacologic half-life is about 10 seconds. Adenosine causes a decrease in systolic and diastolic blood pressure of about 8 to 10 millimeters of mercury. Heart rate increases by about 14 beats per minute. The patient should not eat or drink for at least 3 hours before administration and avoid methylxanthines, including any caffeinated products and theophylline medications, for 12 hours. Adenosine is infused at 140 micrograms per kilogram per minute using an infusion pump to administer the adenosine at a constant rate over 4 to 6 minutes. The radiotracer is injected at the halfway mark depending on whether a 4 or 6 minute infusion is used. The adenosine infusion must continue for several minutes after radiotracer injection. Note, the IV line should have a dual port Y connector, which should be as close to the IV catheter as possible to avoid a bolus of adenosine during administration of the radiotracer. Most of adenosine's effects are self-limiting due to the short half-life of less than 10 seconds and will resolve within 30 to 60 seconds after stopping the infusion. Indications for early termination of adenosine and reversal include persistent hypotension with systolic blood pressure less than 80 millimeters of mercury, development of symptomatic, persistent second-degree or complete heart block or other significant arrhythmias, wheezing, evidence of persistent ischemia manifested by chest pain or ECG changes, signs of poor perfusion such as pallor, cyanosis, or cold skin, technical problems with the monitoring equipment or the patient's request to stop. The reversal agent for adenosine is 50 to 250 milligrams of aminophylline intravenously. However, it's only rarely required. If an aminophylline administration is required, it should be delayed for at least 1 minute after the radiotracer administration. Administration of the aminophylline less than 1 minute after the tracer injection is likely to reduce the test sensitivity. Indications for adenosine are the same as other stress testing, but specifically for patients unable to adequately exercise and achieve the target heart rate, or those who have ECG abnormalities such as left bundle branch block, Wolff-Parkinson-White syndrome, or permanent ventricular pacing. Contraindications to adenosine administration include bronchospastic lung disease with wheezing or significant restrictive airway disease, Mobitz type 2 or third-degree AV block without a functioning pacemaker, sinus node disease such as sick sinus syndrome or symptomatic bradycardia without a pacemaker, systolic blood pressure less than 90 millimeters of mercury, uncontrolled hypertension greater than 200 over 110 millimeters of mercury, ingestion of caffeine or methylxanthines, known hypersensitivity, unstable angina, or acute coronary incident within 2 to 4 days. The relative contraindications include heart rate less than 40 beats per minute, Mobitz type 1 atrioventricular block without a pacemaker, severe aortic stenosis, or seizure disorder. The side effects of adenosine are due to non-target receptor activation, such as A1 receptor activation, which causes atrioventricular block, A2B receptor activation, which causes peripheral vasodilation and bronchospasm, and A3 receptor activation, which causes bronchospasm too. Minor side effects occur in approximately 80% of patients and include flushing, chest pain, which is not specific for coronary artery disease, dyspnea, dizziness, nausea, and symptomatic hypotension. Other common side effects include AV block, second-degree AV block, complete heart block, but only in 1% of patients, and ST wave depression of greater than 1 millimeter. We thought we had it pretty good with adenosine, but then regadenoson came along and we were really in heaven. Regadenoson is also a direct coronary arteriolar vasodilator through the activation of A2A receptors, again causing coronary vasodilation and increased coronary blood flow. The maximal plasma concentration of regadenoson is achieved within 1 to 4 minutes of IV administration, and this parallels the onset of the pharmacodynamic response. Regadenoson has 3 action phases. The initial phase has a half-life of 2 to 4 minutes. The intermediate phase lasts 30 minutes, and it coincides with the loss of the pharmacodynamic effect. And the last phase consists of a decline in plasma concentration with a half-life of about 2 hours. Most patients have an increase in heart rate and a decrease in blood pressure within 15 minutes of regadenoson administration, with blood pressure decreasing 8 to 10 millimeters of mercury and heart rate increasing by about 25 beats per minute. The patient should not eat or drink for at least 3 hours before administration and avoid methylxanthines, including any caffeinated products and theophylline medications, for about 12 hours. Dipyridamole should be withheld for at least 48 hours before regadenoson administration. The recommended dose of regadenoson is 0.4 milligrams in 5 mL of solution. It should be given IV over 10 seconds using a 22-gauge catheter or larger. A 5 mL saline flush is administered immediately after the injection of regadenoson. The radiotracer is injected 10 to 20 seconds after the saline flush using the same IV line used for regadenoson. Indications for early termination of adenosine and reversal include persistent hypotension with systolic blood pressure less than 80 millimeters of mercury, development of symptomatic persistence, second-degree or complete heart block, or other significant arrhythmias, wheezing, evidence of persistent ischemia manifested by chest pain or ECG changes, signs of poor perfusion such as pallor, cyanosis, and clammy skin. The reversal agent for adenosine is again 50 to 250 milligrams of aminophylline intravenously. Aminophylline administration should be delayed for at least 1 minute after the radiotracer administration. The indications for regadenoson are the same as adenosine. The contraindications and relative contraindications are also the same as adenosine. However, there is one additional relative contraindication with regadenoson in patients with seizure disorder. Regadenoson may lower seizure threshold, and aminophylline is not recommended in cases of seizures associated with regadenoson. Of note, the seizures associated with the use of regadenoson may be either new onset or may be reoccurrences. In addition, some seizures are prolonged and may require urgent anticonvulsant management. Common side effects of regadenoson include headache, dyspnea, flushing, chest discomfort or pain, angina, dizziness, nausea, abdominal discomfort. Regadenoson can also cause rhythm or conduction abnormalities in about 26% of patients, and this includes first and second degree AV block. Most adverse reactions begin soon after dosing and typically resolve within 15 minutes. Most headaches resolve within about 30 minutes. 50 to 250 milligrams of aminophylline by slow IV injection over 30 to 60 seconds can be given to attenuate severe or persistent adverse reactions. The last and most hated interventional cardiac medication is dobutamine. Nobody likes doing dobutamine stress tests, and thankfully, they're relatively rare. Dobutamine is a synthetic catecholamine stress agent that works by stimulating beta 1 and beta 2 receptors, resulting in an increase in heart rate, blood pressure, and myocardial contractility, similar to exercise. Dobutamine increases regional myocardial blood flow based on the physiologic principles of flow reserve previously discussed. At a dose of 20 micrograms per kilogram per minute, dobutamine-induced coronary flow heterogeneity is similar to that induced by exercise, but it is less than that induced by adenosine and dipyridamole. The plasma half-life of dobutamine is 2 minutes with an onset of action in 1 to 2 minutes. However, up to 10 minutes may be required to obtain the peak effects. The patient should not eat or drink for at least 3 hours before administration and they should avoid beta blockers for 24 hours. An infusion pump is necessary for dobutamine administration along with a dual port Y connector to inject the radiotracer. Dobutamine is infused beginning at 5 or 10 micrograms per kilogram per minute, which is increased at 3-minute intervals to 20, 30, and 40 microgram per kilogram per minute. The weight-based dose is used up to a weight of 250 pounds. The radiotracer is injected at peak heart rate with dobutamine infusion continuing for 1 minute following tracer injection. Target heart rate of 85% of the predicted maximum heart rate is desired. Indications for dobutamine termination include achieving greater than 85% of the age-predicted peak heart rate after maintaining it for 1 minute following radiotracer injection, severe hypotension with systolic blood pressure less than 80 millimeters per mercury, severe hypertension with systolic blood pressure greater than 230 millimeters mercury, or diastolic blood pressure of greater than 115 millimeters mercury, significant cardiac arrhythmias, knowing that termination for ventricular tachycardia is more likely with dobutamine than with the other stressors, severe chest pain associated with ST depression of 2 millimeters or greater, and signs of poor perfusion, including pallor, cyanosis, or cold skin. In the event of severe hypertension, where blood pressure is greater than 210 over 110, significant cardiac arrhythmia, severe chest pain associated with ST depression of 2 millimeters or greater, dobutamine effects can be reversed with IV administration of a short-acting beta blocker such as 0.5 milligrams per kilogram of esmolol over 1 minute or 5 milligrams of metoprolol. Dobutamine is a secondary pharmacologic stressor that's recommended only in patients who cannot undergo exercise and who have contraindications to pharmacologic vasodilator stress agents. It is preferred in patients with a history of significant reactive airway disease or severe obstructive pulmonary disease. Dobutamine, similar to exercise stress, should not be used in patients with left bundle branch block, pre-excitation syndrome, or paced rhythms. Dobutamine is contraindicated in patients with unstable angina, acute coronary syndrome, or if it's been less than 2 to 4 days after an acute myocardial infarction. Patients with hemodynamically significant left ventricular outflow tract obstruction, atrial tachyarrhythmias with uncontrolled ventricular response, prior history of ventricular tachycardia, uncontrolled hypertension with systolic blood pressure greater than 200 millimeters of mercury or diastolic blood pressure greater than 110 millimeters of mercury, patients with known aortic dissection, and known hypersensitivity to dobutamine. Relative contraindications for dobutamine include patients who are on beta blockers because the heart rate and inotropic responses to dobutamine will be blunted, severe aortic stenosis, patients with symptomatic large or symptomatic aortic aneurysm, left bundle branch block, and paced ventricular rhythms. Side effects of dobutamine are dose dependent and vary depending on the maximum infusion rate obtained. The common side effects include chest pain, palpitations, headache, flushing, dyspnea, significant supraventricular or ventricular arrhythmias, ischemic ST segment depression. Did I mention that I hate dobutamine? All right, so there you have the fourth Pharmacy 15 reviewing cardiac interventional or pharmacologic stress agents used in nuclear cardiology. These test medications simulate effects of exercise on the heart with two main categories: vasodilators, including dipyridamole, adenosine, and regadenoson, and catecholamine agents, which is dobutamine. Vasodilators induce a coronary steal phenomenon, increasing blood flow to normal vessels at the expense of diseased ones. Dobutamine, on the other hand, increases heart rate, blood pressure, and myocardial contractility similar to exercise. While exercise stress testing is preferred, pharmacologic options are crucial for patients with limitations or specific contraindications. Dobutamine is generally a secondary option used when vasodilators are contraindicated. Now, take a moment to review your notes, review the summary document I uploaded to Moodle, and work on the flashcards. You should focus on the mechanisms of action and dosing for these medications and make sure you can calculate the doses. See you next time, well, sort of. And next time I'll be reviewing the cardiac adjunct medications like aminophylline, atropine, and nitroglycerin. Reach out if you have any questions and keep studying.